Over to the speaker.
Respected chair, teachers and friends. The topic that I have been assigned is to discuss about Eplet matching. Since it's an evolving topic, please excuse if I'm getting very elementary on it. And we had almost the same discussion yesterday in the transplant immunology workshop, so it's basically repeating the same thing. So basically, when it comes to histocompatibility, the fundamental thing is identifying the non-self. And from HLA standpoint, the recipient looks at the donor and looks what's foreign, what's the mismatched. And there is these historical graphs which has been updating showing the same trend that increased antigen mismatches leads to inferior outcome. But the challenge is that the alleles are daily increasing with the molecular typing methods that we have, and it is 42,000 and counting. And so these graphs get splayed, and you have this appearance only if we have like 200,000 patients, okay? With, you and me might be doing like few hundreds or thousands in our lifetime. And in that scenario, except for the zero antigen mismatches, we won't be able to appreciate this playing of these graphs. So it was Professor Dickinson who met up and who reignited the concept of epitopes and eplets, which was there even at the Terasaki era. But he came up and showed that it is very important, because unless and until we have some sort of a deep dive into the HLA system, we will not be able to tease out the nuances of the antibody responses. So HLA, if you look, it's very homologous. All these HLAs have more common things between them. And there are few, like 20 amino acids making these 250 odd amino acid long proteins. They have certain areas of highly polymorphic islands or patches of immunogenicity, which we call as the eplet. So it's just like you have a certain pattern of eyebrows and mustaches and nose and eye, which will give you the combinations, the mix and matches will give you a lot of faces. So if you split the whole, out of the 42,000, the class 1 alleles are like 27,000, which is nothing but 252 eplets, okay? So of the 252, if you look, almost 75% is seen in multiple alleles. So that is how it has narrowed down. So matching for 27,000 alleles, if we cut size it to like 250 epitopes, we think that as a clinician, it will be very easy for us to compare between the individuals. So this is the data from Canada, where it's a very multi-ethnic population, as we know. So this is the HLA spread of the population. So we see that certain HLAs are very common and very certain, and good majority are seen in a very few people. So to get a HLA matched individual is not that easy. So when the same population was spread across from a eplet standpoint, what they found was that there was more commonness. The curve was little more flat, a lot more sharing of eplets are happening between the population. So these things fascinate us to find, it is better that we can, better or easy to find a eplet matched rather than allele matched donors. So how it works is that we have a lot of software tools. So we populate the higher resolution HLA data. So it extracts out the epitopes. Each HLA, it gives which all eplets are important in that. But the problem is that, we are identifying more eplets day by day. And rather than identifying, we have to understand the quality of it. Some are like antibody verified, some are just sitting there without any immunogenicity. So that is where it is evolving right now. So we have to disconnect. A patient is no more a HLA identified right now. He is nothing but a set of epitopes. And then now a donor comes. What it looks is what are the mismatched eplets. And what we tend to believe is that less the eplet mismatches, better is the outcome. So I have a recipient right now. So this particular recipient, HLA, has been run across 3 different donors, and I'm looking at the eplet mismatch. So I find the third donor, which eplet mismatch 20 is supposed, which I presume to be a better donor. But what is the data out there? Okay, is it practical for a living donor transplant program in India? 90% of our transplants are living donors. our average transplant age is between 30 to 40. So do we have the liberty of having multiple donors? Definitely no. So what's the take home that we can have as of the evidences that we have right now? So if you look at the data, this is again from Canada, Manitoba. They have like almost 700 patients followed up for 12 years. So leave alone the green graph, it is like zero mismatch. But they could not tease out the difference between the DRs and DQ at the allele level. But when the same population was populated from epitope standpoint, what they found is that irrespective of the alleles, antigens, they could find inferior outcome with more Eplet mismatches. But there's a caveat there. These patients had increased DSA, increased rejections, and increased graft loss, but the vulnerable group who faced this were the patients with non-compliance or non-adherence to immunosuppression. So the data, now the epitope the importance has come just narrowed down to class 2. So this is another paper from Belgium, from Nassen's group. Again, almost 1,000 patients, follow up for almost 8 years. Again, they found only the DQ Eplet mismatches having any impact on long-term graft outcome. So with the evidence now, we can say that increased Eplet mismatches at class 2 is something that we cannot be happy about, but it is not a gatekeeper to decide on transplantability or on acceptance or denial of a pair for transplantation. So I think for a prospective transplant, using an Eplet in an Indian scenario is just a hype, but the take homes will be like, if you are in a living donor program, if your flow cross match is negative, there's no role for Eplet matching unless you have multiple donors, and that too the importance is only in class 2, because all these data are from retrospective studies, and we need more data on the quality and the quantity of the epitopes that are important to us. So as a clinician with a patient with increased class 2 Eplet mismatch, the number I'm not sure, I'll be little worried or hesitant in playing with his immunosuppression. That is the take home for a prospective renal transplant. But I don't want to leave it in a dismal note, but there is some hope for Eplet analysis in day-to-day clinicians practice. So what I have identified is that there are these 3 areas where Eplet can be used in a meaningful way. So one is to give, the single antigen bead. You have all clinicians, from the labs we get the readout, but we don't know how to make sense out of many of these graphs. So how Eplet can be used is one of the points to be discussed. Second is to identify a memory response in patients undergoing retransplant. Again, we have a very young population whom we retransplant, so we have to have better outcomes on this population. Third is broadly sensitized patients. We don't know what to do with them. Can Eplet help them? So coming to the first one, coming to the single antigen bead. So these are data from Professor Terasakis and Professor Appel's lab. They are big giants in transplant immunology. So from Terasakis' lab, what they found was around 60% of the individuals, and in Appel's lab, 25% of the non-sensitized individuals, predominantly male, had anti-HLA antibodies by Luminex method. So we know that's a noise. It's not a definite antibody that we should be worried about. So that's why the trend for MFI has changed, and the people started to looking at Craig patterns. So Craig and Eplet are the same thing. One thing is that Craig is the serological era, Eplet is the molecular era. So we had all these things identified when we had the CDC platform. People found that these are the groups that usually, because they share a common Eplet. That's why if I develop an antibody against the A1 Craig, that means I have an antibody against a particular epitope that is shared by all these HLA alleles. That's why I develop an antibody against that Craig. So all these we have identified which are the epitopes that explain for these Craigs right now. Okay, now coming to a case. So I'm going to discuss certain real cases which help us. Okay, so these are 2 patients, X and Y. They have pretty much the same antibody profile. MFI is around 5,000 to 6,000. So we don't know what it is. If there is something pointing towards the donor, you might call it a DSA, you might react to it. But just like you put a Doppler color in the ultrasound, let's put the Eplet into picture, okay? So this particular patient, this particular antibody is not explained by any epitope pattern that we know. Okay, so, and I do a cross match. So, your cross match is your final gatekeeper. So, with a non-meaningful antibody pattern, a cross match negative, I'm a little more comfortable in taking this patient. Okay, now the other patient, almost the same pattern, but there are very strong epitope pattern that explains it, and the cross match is positive. So, in that scenario, I would wait for a donor without this Eplet pattern. So, this is. So again, another antibody profile. This is a patient actually who lost graft in the first 1 month, and father was the donor. So this patient have lost the graft due to ABMR, and we know that the patient has reacted to some mismatched Eplet between the father and the recipient. So which are the mismatched Eplets? Okay, these are the mismatched Eplets. But these mismatched Eplets were not explaining this antibody profile. So either my typing is wrong or this antibody profile is wrong. Okay, so the Eplets that are describing this antibody profile has nothing to do with the mismatched Eplets. So there is somewhere wrong has happened. So what we did was that we did the same thing with the different vendors single antigen bead. Then everything falls into picture. He had developed an antibody against 104 AK. So this is, we can tease out whether it's a genuine pattern or not. So it was actually some technical error happened with the first test. Now, third is that, the whole Luminex beads is just 100 beads, and we have like 42,000 alleles. Okay, so many a times we clinicians are really worried. You have some antibody which is not there in the bead, so their Eplets can help you. So this is a patient with a A2 Craig antibody. Okay, so these are the A2. So see, A201, A206, A203, and in Kerala at least, 30% of our population has got A211, which is not represented. Okay, and when I have and A2 is a very common pattern. Okay, so what we can see is that this is explained by 127 AK. If you go at the directory, A211 is a part of that 127 AK. So this is so you can give life to your single antigen bead profile. Coming to the next is to transplant in retransplant patients. Okay, so I know that this patient have lost the graft due to a chronic ABMR with the primary graft. So I know that there is some Eplet to which or multiple Eplets to which my patient has reacted. Okay, so this is the patient. His mother-in-law was a donor. Lot of mismatches. Again, ABMR in the first month, but we could treat and salvage the kidney for a couple of years, and his back on dialysis, came for transplant. So this is the antibody pattern that he had. So he has reacted with his mother-in-law. These are the mismatched Eplets that he had with his mother-in-law. Now, this antibody profile should be explained by one of these 6 Eplets or multiple. So what we found was that 55 pp and 66 ER could explain this antibody pattern. If you look at 201, 402, it's not there. It's actually a nuisance noise there. It is not a genuine antibody. Antibody test, patient was transplanted in 2018. In 2024, a particular pattern has stood all these years, means it should be a genuine profile, which is fitting only to these 2 patterns. So I can tease out these 2, but that's not the context, question here. So I have to find a donor without 55 pp and 66 ER. So multiple donors walked in, his wife walked in, sister walked in. Finally, we could get a paired kidney without these epitopes. So in retransplanting, how should you cross the memory is what Eplets can help us. Third is the highly sensitized patients. This is like, get broadly sensitized patients and we are standing helpless. So we need some entry, some defects through which we can penetrate and transplant this patient. This is a patient. So this is an antibody profile, a real patient. So what I'm left with is that I should have donors, only this many donors I can have. That means I'm very limited. I might have to wait for years to get one, or you should have an allocation system that facilitates that. So I have to increase my donor pool. So what we do is that, what explains this antibody profile? So when you look these, I have put all the Eplets, antibody verified, high express, there are different quality criteria for Eplets. We may put all these things, still I am finding that there are many alleles which are not explained by these epitopes. That my transplantability window has increased. All these green spaces that I see is that my transplantability has increased. This has been proved and done by people in Europe long back at the antigen era, So what they do, this is the acceptable mismatch program. And now they have factored the Eplet into it, the same mechanism. So we identify certain Eplets which not are explained or which not account for antibody that are acceptable. These are the acceptable mismatches that we can opt for. And their outcome had been really excellent. So to conclude, I think in a broadly sensitized patients, Eplet can filter out at least the most potent antibodies that we should be worried about, and the transplantability can be increased. But again, all those greens I have to confirm with a flow cross match. So to conclude, prospective eplet matching, I don't think that Indian scenario it is anything that we can take. But that too, only for class 2 we have data. If you have multiple donor options for paired kidney transplant, I mean a particular patient has multiple donor options. But one thing that we use Eplet in paired kidney donation is that certain facilitators come to help others. So they might have an advantage there in the DQ. So we see to that they should not lose an advantage that they have. Suppose they are just 5 or 6 Eplet mismatch of DR and DQ. At the end of the day, facilitating a transplant, looking at the blood group and everything and age, and they are getting a kidney far mass mismatch. That is an unfairness to the facilitating donor. And the third thing is that as a clinician, I'd be worried in curtailing or playing with the immunosuppression if I have a lot of class 2 Eplet mismatches. And just discussed in clinical practice, giving life to your single antigen bead profile, to assess the memory that I should cross in my retransplant patients, and to find a window of opportunity to penetrate the broad antibody profile in transplant in the sensitized patients are the few scenarios where I think day-to-day a transplant physician in India can bang upon. Thank you.